So welcome to this session. Just a note that I'm calling from the Fraser Health region, and that is the land of the Katzie, Semiahmoo, Kwantlen, Coquitlam, and Tawasin First Nations. And I am so grateful to both live, work, and play on these lands. So today we're going to talk about pharmacotherapy approaches for alcohol use disorder, and really the idea here is to go over the goals of pharmacotherapy and treat as a treatment for alcohol use disorder, and some recommendations for how to decide which first line option versus alternative options need to be considered. And before we get started, I'd like to go through some statements of acknowledgement and disclosure. So the material is made possible through a financial contribution from Health Canada and the General Practice Services Committee. Those of us that are GPs know it as the GPSC, and that's a partnership of the Government of BC and the Doctors of BC. A note that the views expressed herein do not necessarily represent the views of Health Canada or the GPSC. And this is me. Nicole has already done a wonderful job rattling off all the stuff that I do. Other stuff about me that usually doesn't make it onto a slide is that I'm the mom of 2 kids, and that I live in Delta in the Fraser Health region. And important to note that I have no relationship with commercial interests to disclose. With regards to disclosures of commercial support, the BC ECHO team would like to disclose financial support from the Health Canada and the GPSC as noted, as presented on this slide, as well as in-kind support from the BCCSU, and also a note that the BCCSU is providing an honorarium for my participation in today's session, which I do disclose as a potential conflict of interest. Steps to mitigate that potential bias include all of the content has been reviewed for potential bias. It's been validated by members of independent scientific planning committees, and it has been approved for accreditation submission. So what are we going to do for you by the end of this hour? We're hoping that by the end of the session, you will be able to identify the goals of treatment for alcohol use disorder. You'll be able to describe first-line pharmacotherapies for alcohol use disorder and considerations for their use. Have some knowledge on second-line pharmacotherapies and when you would use them, and have the ability to have an approach to prescribing pharmacotherapies and apply some clinical considerations when you're trying to choose between which therapies to use. And just a quick note with regards to where does pharmacotherapy fit in the big picture, right? When you're looking at a patient who engages in the use of alcohol use disorder, if you look at it from a clinical pathway picture, like any other disease, it starts with screening and brief intervention, which includes education and potentially some counseling. Then, of course, there is the consideration for whether or not an individual requires withdrawal management, and your strategies for that will be based on the perceived risk of developing severe withdrawal. And then really the part that we're going to talk about today is the continuing care piece, and specifically the pharmacotherapy piece, but of course there are other pieces and additional supports that come into play. And so something I want you to keep in the back of your mind as we go through this is pharmacotherapy is an important part of continuing care, but that, really you need to look at this as prescribing it in alignment with patient-centered treatment goals. So really look into what is it the patient is hoping to achieve. It can help patients with moderate or severe alcohol use disorder meet their treatment goals, and that might be anywhere from reducing marginally to stopping or abstaining entirely. It can help reduce alcohol cravings. And just a really important note that abstinence from alcohol isn't always a desired or even realistic treatment goal for all patients. And so really checking in with where the patient is in that moment and what they are hoping to achieve will result in a more successful patient-doctor relationship, or patient-prescriber relationship, I should say. Um, and a note that in the absence of abstinence, pharmacotherapy can still be used to support a reduction in drinking and alcohol-related harms, particularly noting that alcohol is a toxic substance that has dose-related impacts. So a reduction is in fact a success. All right, so let's get to the meat of the presentation. So these are the agents that we're going to spend some time discussing today, and really they're broken into first-line pharmacotherapies and alternative pharmacotherapies. First line being naltrexone and acamprosate, and defined as such because of the bulk of literature that's available to them, but also that they are Health Canada approved for the indication of alcohol use disorder. And then alternate pharmacotherapies, gabapentin, topiramate, and disulfiram. Gabapentin and topiramate being substances that, or medications that we use off-label, and then we'll have a discussion around disulfiram and how it's a medication that we don't actually routinely use that commonly anymore. So let's start with the first line pharmacotherapies, and let's start with naltrexone. So I'm sure a number of you have come across naltrexone or naloxone in the addiction medicine work that you do in the context, of opiate use disorder. But it has a place for us here in alcohol use disorder management as well. So as many of you, I'm certain, are aware, it is an opioid agonist that blocks the euphoria associated with alcohol consumption. A number of my patients refer to it as a buzzkill, and that's actually what we're trying to achieve when we give this to patients. So there's actually great evidence that that speaks to the safety and efficacy of naltrexone in the treatment of individuals with alcohol use disorder. It's got good evidence for reducing heavy drinking days and the amount of alcohol consumed. And it's particularly effective at preventing a return to heavy drinking if an individual does continue to use alcohol. So when do you want to show a bit of caution, or perhaps consider other agents? According to the product monograph, you want to avoid this in individuals with acute hepatitis, and I will tell you that clinically I do that. I delay considering naltrexone if I'm sitting across from an individual who's acutely unwell and presents with hepatitis. Liver failure, we're starting to shift our ideas and our approaches to individuals with liver failure. I would suggest, if you have limited experience with naltrexone and you have a patient with liver failure, this is a consideration you want to make with the assistance of an expert. So either calling the 24/7 line or speaking to your community or local addiction medicine experts. For sure, you do not want to give individuals who have a need for opioids naltrexone, because it is an antagonist. It will result in acute opioid withdrawal, and that is acutely uncomfortable for our patients. We do show some caution in renal or hepatic impairment. You want to consider some caution in individuals who may be using other medications who have hepatotoxic impact. Like with most other things, taking a really good risk-benefit assessment before you provide this to individuals who are pregnant or breastfeeding, and then of course in pediatric patients that are less defined here as less than 18 years old. The benefits of this medication are many, but one is really the dosing, in that it's commonly taken just once daily. So for ease of administration, I think this one wins. And there is some increasing evidence to support targeted dosing, so almost as a PRN. So taking it prior to planned drinking. This particularly comes into effect when you're seeing patients who have binge patterns that are quite reliable. So I'm sure most of us have had patients who really only drink 3 days a week, the weekends, but have consequences that are quite significant as a consequence of that. All right, so let's move on to acamprosate, the other first-line agent. So I love that the first line says mechanism of action not well understood. That I'm sure puts a lot of confidence when the first line says we're not really sure how it works, but it's true actually. We do think that it has something to do with its effect on the GABAergic glutamate-based systems in the brain, which ultimately help with symptoms of alcohol withdrawal and reducing alcohol-related cognitive cues. It has a really well-established evidence base for safety and efficacy in the treatment of alcohol use disorder. And it's been found to reduce the likelihood to return to drinking at all. So this is a medication that we look at when our patients' goals are for abstinence. When do we want to show some caution or perhaps consider another agent? So for acamprosate, severe renal impairment is a contraindication. So that's a GFR of less than 30, or when patients are breastfeeding. Some caution in moderate renal impairment. So a GFR between 30 and 50, and you would simply use a reduced dose in that setting. Some caution with pregnancy, and then of course in our other patient populations that aren't routinely studied, so pediatric and geriatric patients. The common dosing is 2 tablets 3 times a day. So when we're looking at naltrexone or acamprosate, with both of them, the recommendation is that an individual does not need to be fully through their acute withdrawal prior to starting treatment. You're going to, do this assessment on a case-by-case basis, trying to balance, the potential side effects may mimic some of the withdrawal symptoms, and choosing carefully based on that. That being said, in terms of safety, naltrexone is perfectly safe to start while patients are still using, but potentially could be more effective. And of course, there's the reduced side effect impact if started when a patient is through that initial acute phase. And usually we define that as the first 5 days after cessation or significant reduction of use. Acamprosate is known to be safe while patients are using alcohol, but again, you might have actually just better patient buy-in if you started after that acute withdrawal piece. As mentioned in the few slides before this, have a conversation with your patients and see what is it that they're hoping to achieve with pharmacotherapy. So naltrexone being the recommended agent if individuals want to consider using alcohol, but have a reduction in the heavy drinking days, and acamprosate really being the go-to for individuals who are aiming for abstinence. And then just a note again about contraindications that we covered. So all of that being said, there are individuals who may not experience benefit from first-line therapy, or they may actually have contraindications to even trialing it. And so, having that process of a shared decision-making approach with the patient is so important in these cases. Again, reviewing the goals, what the patient needs, what the patient can even accomplish, and what the patient's preferences are. So let's talk about some of the alternative pharmacotherapies, starting with gabapentin. I think because it's the one that everyone here will probably have the most familiarity with, and if not a familiarity with prescribing, a familiarity with seeing it on our patients' pharmanets and medical records. As you know, it is an anticonvulsant medication, and we use it off-label for the treatment of alcohol use disorder. So if you are doing this with your patients, please do let them know that it is off-label so that they can make an informed decision. So the evidence for gabapentin demonstrates reduced heavy drinking days. The doses that were studied were from 600 to 1800 milligrams per day, and the 1800 milligram per day is what was seen to be superior. We do have a potential for using gabapentin for physiological dependence and withdrawal syndromes. So when you're assessing whether an individual is high risk or low risk for complicated withdrawal, for individuals who are low risk for complicated withdrawal, gabapentin might be an option. Some things to consider with gabapentin are the fact that we do have populations in our patient population who actually enjoy the feeling of dissociation or are looking, perhaps enjoy is the wrong word, are looking for that effect of dissociation that they can feel with gabapentin. Some people will find that the use of gabapentin actually potentiates euphoric effects of other substances. And if you are worried about that, considering opportunities to prevent diversion. So strategies around prescribing, witnessed ingestion, blister packs, what have you. So the point here is it doesn't necessarily mean that individuals can't use gabapentin, but you might have to put in a few mitigation strategies around risk. So moving along to topiramate, and those of us that are family doctors in the audience do have comfort with topiramate, but we use it in other situations. So it is another anticonvulsant medication. We use it off-label for other things such as migraine prophylaxis, and in fact, it can be used off-label for the treatment of alcohol use disorder. The evidence suggests it may help with heavy drinking days and craving, and as well as supporting abstinence. And the bulk of evidence for topiramate is less than it is for the other agents, but we do have studies to support the use of it in alcohol use disorder. It's considered one of the challenging things. It depends, I guess, on the specific patient, is that you can't just start at the optimal dose. There is a gradual dose titration that needs to occur over several weeks to avoid severe side effects. And that can be a time in which you can lose patients. Like there can be an attrition effect. And the doses range from 100 to 300 milligrams per day. So let's move on to disulfiram. And I feel like this slide needs to be a little bit more exciting, like fireworks or something in the background. So disulfiram is often the medication that patients think we're offering when we talk about medications for relapse prevention. It is colloquially known by its brand name, which is Antabuse. And the first sentence here is a bit of an understatement. So it is an aversive agent, and it causes unpleasant physiological reactions when alcohol is consumed. It actually is approved for treatment of alcohol use disorder by Health Canada decades and decades and decades and decades ago. I'm assuming there's a few of you, at least on this call, who have seen what we refer to as a disulfiram reaction, and people get exceedingly sick if they take it in the context of having recently consumed alcohol. That being said, there is some evidence that demonstrates reduced heavy drinking days, weekly consumption of alcohol, and relapse rates in supervised treatment settings. That really seems to be the situation in which it works well. And in kind of pragmatic or real world settings, adherence is quite low. So if you know that taking a medication will make you violently ill in the context of drinking alcohol, most people will not take the medication. And it is, as a consequence of what I've noted, it isn't really recommended for the treatment of alcohol use disorder unless the patient really, presents with a preference for this approach and kind of has these like unique supervised settings that may allow for this to be a good option. So rural and remote communities, which I know a number of you are calling in from, things to think about. People have to travel longer distances or potentially leave their communities for appointments with prescribers or access to pharmacies to fill prescriptions. Um, Consideration potentially can be given for remote follow-up appointments with telemedicine or virtual health options. For people that are on stable doses, consider extensions of prescriptions to minimize the need for travel. I personally, having lived in a rural environment and driven on highways in the winter, I would say this is particularly a consideration in terms of risk of being out on highways. And things to consider include difficult access for supportive interventions such as psychosocial and community-based supports. So we're almost through, guys. In summary, so pharmacotherapy is important. It's an important tool to consider when you're trying to help patients meet their treatment goals. Naltrexone and acamprosate are first line. Topiramate and gabapentin are considered alternative options, and disulfiram is really something that we would consider only in very few and specific cases. And then just another plug, sit down, have a conversation with the patient in front of you about what it is that they're hoping to achieve, and help them design a strategy that meets those goals. If you run into situations in which you need a little bit of extra help, you are welcome to call the 24/7 addiction medicine support line. As the title indicates, there is someone on the other end, 24 hours a day, 7 days a week. And just also a note that your echo sessions are but one piece in the learning tools available to you. So there's a lot of learning materials that are available, and you can go to the BCCSU website to look at all of the options available. These are some references for things that we spoke about today.